Welcome to The Explainer. Today we're going to explore the utterly fascinating and sometimes incredibly intricate ways the human mind can basically malfunction. We're doing this by breaking down the complete taxonomy of thought disorders. I mean, think about it. We spend literally every waking moment inside our own heads, right? We're constantly listening to that internal monologue. But what actually happens when the very machinery generating that monologue starts to break down? How does a clinician even begin to map out the products of a disordered mind? Let's find out.
Now, just a quick heads up before we dive into the deep end. Please note that all the clinical and psychopathological concepts we're talking about today are presented strictly for educational purposes. We're looking at this whole topic purely through the lens of medical science to better understand human psychology. So please, no self-diagnosing out there.
All right, here's our roadmap for today's explainer. We've got 5 main stops. 1. The anatomy of thinking. 2. The stream of thought. 3. Possession of thought. 4. Content, so delusions and beliefs. And finally 5. Form, which is basically the breakdown of logic itself.
Okay, let's kick things off with Section 1, the anatomy of thinking. Because honestly, before we can even begin to understand the abnormal, we absolutely have to establish how descriptive psychopathology actually maps the mind. We need to know how psychiatrists measure what's normal.
So there's this massive fundamental divide in psychiatry. On one side, you have psychoanalysis. Freud, repressed conflicts, looking for those deep, hidden, unconscious roots. But descriptive psychopathology, it does something completely different. It simply observes and categorizes exactly what the patient is experiencing in their own subjective reality. It literally actively avoids trying to theorize why a symptom is happening and focuses entirely on the what. What is the patient experiencing right here, right now?
And to do this accurately, clinicians rely on a very specific, absolutely crucial tool: empathy. But hey, not the everyday kind of empathy we talk about. In psychopathology, empathy literally means feeling into. It's used as a real clinical instrument. The clinician has to imaginatively step into the patient's internal world to measure their subjective state. This is vastly different from just sympathy, which is basically just feeling with or feeling sorry for someone. If this clinical empathy fails to make sense of a patient's experience, well, that experience is classified as truly ununderstandable.
It's also super important to remember that every single one of us experiences a baseline spectrum of normal thinking. The medical literature generally divides this into 3 types. First up is undirected fantasy, sometimes called autistic or diorderistic thinking, which is, simply put, daydreaming. Then you've got imaginative thinking, which gets creative but stays within the bounds of reality. And third, rational or conceptual thinking. That's the heavy lifting we use to actually solve immediate real-world problems.
Moving right along to Section 2, the stream of thought. Let's look at the actual pace and flow of the mind and see what happens when that baseline starts to fracture.
What's truly wild is what happens when the actual tempo and continuity of your thinking breaks down. We can measure the stream of thought by looking at a few extremes. For instance, is the person's thinking agonizingly slowed down? We see that a lot in severe depression. Or, on the flip side, is it excessively verbose and circumstantial, like they talk in these endless, exhausting circles before finally getting to the point? Or maybe they're experiencing what's called a flight of ideas, where their mind is just racing from one concept to the next like a runaway train, and it's almost impossible to keep up. And sometimes, the stream just abruptly stops completely. That's a phenomenon known as thought blocking, like hitting a brick wall in your own mind.
All right, Section 3, possession of thought. Now, this section asks a really deeply unsettling question. Who actually controls your mind? For most of us, well, the answer feels pretty obvious, right? Us. But in severe psychopathology, the actual ownership of thought turns into a literal battleground.
To grasp this, we have to contrast thoughts that feel totally natural with ones that feel completely alien. Ego-syntonic thoughts are compatible with who you are. They fit like a glove and don't bother you at all. But ego-dystonic thoughts, they cause deep, deep distress because they feel totally incompatible with your sense of self. Think about severe obsessions and compulsions here. The patient logically knows the thought is theirs, but they absolutely despise it and try to fight it, which just causes immense anxiety. But what happens when that boundary of the self just completely collapses? This brings us to a really chilling concept: passivity experiences. We're not just talking about an unwanted thought anymore. This is the genuine, utterly terrifying sensation that you are literally no longer the author of your own mind.
In the clinical world, this is termed thought alienation, and it usually manifests in 3 main ways.
First is thought withdrawal, where the patient genuinely feels a thought has been physically extracted or stolen right out of their head. Second is thought insertion. This is where they feel a foreign thought has been forcefully pushed into their mind from the outside, maybe by the government or some supernatural entity. And third is thought broadcasting. That's the terrifying belief that your completely private, internal thoughts are somehow leaking out of your head and being broadcast aloud for everyone in the world to hear. No privacy left whatsoever.
Okay, section 4, content. We're focusing on delusions and beliefs here. If possession was all about who owns the thought, this section is entirely about what the patient is actually thinking.
When it comes to disordered thought content, delusions are the absolute hallmark. A delusion is a completely false, rock-solid, unshakable belief that just doesn't align at all with the patient's educational or cultural background, and they hold on to it with extraordinary bulletproof conviction. Logic, counterarguments, they bounce right off. These delusions can range from extreme paranoia and grandiosity to truly terrifying hypochondriacal beliefs. For example, some patients have an absolute 100% conviction that they are infested with insects, or, and this is very real, that their internal organs are literally missing from their body.
Now, descriptive psychopathology splits these into two types. Primary delusions are the ones that arise completely inexplicably. There's some morbid internal process and boom, the delusion just happens, fully formed out of nowhere. No psychological bridge at all. Secondary delusions, on the other hand, are actually an understandable reaction to something else going on. Say a patient is experiencing terrifying auditory hallucinations. Well, they might develop a secondary delusion that they're being targeted or persecuted. In a weird way, the delusion is just the brain's logical attempt to explain away the hallucination.
We also have to be careful to separate delusions from what clinicians call overvalued ideas. An overvalued idea is this completely dominating, all-consuming belief. The catch? It might actually have a tiny grain of truth to it, but it completely takes over the person's life to an totally unreasonable degree. A delusion, meanwhile, has no grain of truth. It is an abrupt, entirely implausible departure from reality. And that brings us to our final section, section 5, form and the breakdown of logic. This is where we shift from looking at the content of the mind to the actual structural form of thought itself.
To really get this, we look to the philosopher Karl Jaspers. He used this brilliant metaphor of a woven fabric, saying form and content are like the warp and woof of cloth. Let's look at a wild example. A patient says, "I am pursued by 10,000 hockey sticks." Now, the patient is terrified by the content, the hockey sticks, but as a phenomenologist, the clinician basically ignores the hockey sticks entirely. Instead, they analyze the form, the structural fact that a false persecutory belief exists at all. You see, content is colored by a person's life and experiences, but the form, that is dictated entirely by the underlying illness. Which leads us directly to formal thought disorder. Guys, this isn't just about having a weird or eccentric belief. This is a fundamental breakdown in the very mechanism and conceptualization of logic itself. It often results in what's known as concrete thinking. The patient entirely loses the ability to understand symbols, sarcasm, or abstract metaphors. They take everything perfectly literally. Basically, the structural wiring of thought is what's failing here.
So how do clinicians categorize the structural breakdown? Well, researchers like Norman Cameron noted that patients often manifest something called asynthesis. That's where thoughts just completely lose their connections to one another. Or they might start heavily relying on metonyms, meaning they swap out exact words for these weird, imprecise approximations. Then there's over-inclusion. This is wild. It's where the mind totally loses its filter. Suddenly a flood of wildly irrelevant information pours into their brain when they're just trying to solve a simple problem.
Another major figure, Kurt Schneider, took this even further by categorizing the objective speech patterns you hear in formal thought disorder. He observed things like derailment, where thoughts mysteriously just slide right off the track, substitution, where a major thought is completely swapped out for a totally minor one, and omissions, where thoughts just vanish into thin air, leaving this bizarre, senseless gap in logic. Sometimes he'd see fusion, which is literally mashing completely unrelated ideas together. And finally, driveling. That's exactly what it sounds like. A complex thought simply loses all its organization and melts into a disorganized mess.
Remember, psychopathology is ultimately about the patient's subjective experience. From the inside looking out, Schneider described patients experiencing this as transitory thinking, literally feeling these sudden, agonizing gaps interrupting what they meant to say. Or subjective driveling, where the patient actually knows their complex thought is falling apart and losing organization, but they just can't stop it. Or even desultory thinking, which are these terrifying moments where sudden random ideas forcefully hijack their normally correct grammar. Imagine how frustrating that would be.
Honestly, looking at these incredibly complex categories leaves us with a pretty profound realization. It's a stark reminder of the sheer fragility of our own logic, just how easily the stream, the possession, the content, and the form of our own reality can just unravel. But more importantly, I think it highlights the immense, almost unimaginable level of clinical empathy required to reach into a disordered mind, sit with it in the dark, and truly try to understand its reality. Think about that for a while. Anyway, thank you so much for joining me on this journey through the taxonomy of thought. I'll catch you on the next explainer.